Hi, everyone. My name is Dr. Debbie Stevens, and I am the director of the CLL program at the University of North Carolina, Chapel Hill. And I am joined today by my friend and colleague, Dr. Jeff Sharman, who is the director of hematology research at US Oncology and Sierra Canyon Institute. So I'm very happy to have you with me here today to talk about some important research that you presented at ASH this year. So thanks for joining us.
So thanks for having me.
First of all, we're going to be talking about a drug called Pirtobrutinib. And so what I would love if you could just start out is tell me, what is Pirtobrutinib and how is this different from the other drugs that are available currently?
That's a great question, Debbie. Thanks so much for having me. So, maybe I'll just answer this a little bit historically and then bring us up to where we are today. But BTK inhibitors are a family of drugs. There's several of them out there. And the very first one to come along was ibrutinib. And most drugs work by fitting into what we call a binding pocket on an enzyme. So it's sort of like there's a little carve out in the enzyme, and the drug fits inside that pocket really well. But ibrutinib and the drugs that followed are a little bit different. Instead of just fitting into the pocket really well, it actually forms a chemical bond. And most drugs aren't made that way, although a growing number are. And when ibrutinib first came out, that was fairly unconventional, although, as I made mention, more drugs have done so. So the first generation BTK inhibitor was ibrutinib, and then two subsequent BTK inhibitors came along and were approved, and those were acalabrutinib and zanubrutinib. And those were what we call the second generation BTK inhibitors. And they also formed chemical bonds, but they had gone through some additional steps to try to minimize side effects and change the way the body, change the way the drug navigates the body and so forth. But altogether, those three drugs were what we call covalent inhibitors. First and second generation drugs were covalent inhibitors. Where pirtobrutinib is different is it follows the pathway of maybe the more traditional drug development, which is where the drug fits into this enzyme binding pocket much better. It doesn't necessarily form a bond, but because it fits in there really well, it can continue to inhibit the BTK enzyme after resistance to some of the first and second generation BTK inhibitors. So when patients are on ibrutinib or acalabrutinib or zanubrutinib, oftentimes after enough time, they can become resistant to it because of certain mutations that develop. But where pirtobrutinib is different is it is a non-covalent inhibitor, which means it doesn't form that bond, and it can continue to inhibit the enzyme even in the setting of resistance to the first or second generation BTK inhibitors.
Yeah, that's really important, and it's a really great drug, and it's really the topic of this clinical trial that you presented called the 3-2-1 study. So if you could just walk us through the design of the study, for example, who was enrolled and what treatment arms were studied, and what was the main question you were trying to answer?
Yeah, absolutely. So, some of this has to do with just the way drugs are developed. Oftentimes they're developed for patients who don't have other options, sort of end of the road type patients. But then as the drug is around longer, you can move it earlier and earlier into the treatment paradigm. And since this drug works after the first and second generation BTK inhibitors, what we would like to try to do is get the drug available for those patients. Now, when patients are treated with CLL currently in the frontline setting, BTK inhibitors are the most common choice. Some patients get BCL2 inhibitors first, which is a different class of drugs. But if a patient experiences progression or treatment failure after a covalent BTK inhibitor, their option right now is either a BCL2 inhibitor, or there really aren't other options. So this study asks the question, does pirtobrutinib beat the standard of care following a covalent BTK inhibitor? Now, you can reasonably ask, what is the standard of care in that setting?
Right.
And for many patients, they would go on to receive venetoclax, a BCL2 inhibitor. However, not every patient is suitable either medically or socially or even has access to venetoclax in the international setting. Um, and then there are the patients who've had both. And so in this study, roughly half of patients had prior venetoclax and half had not. But that wasn't so much the inclusion criteria. The inclusion criteria was whether or not you'd had a prior BTK inhibitor. And so in this study, I think the number I'm going from memory here was something along the lines of 70 to 80% of patients had been on a prior BTK inhibitor and experienced disease progression on that BTK inhibitor, meaning once you're resistant to one of the first or second generation BTK inhibitors, you're generally resistant to all of them. And so high proportion of patients had resistance to prior BTK inhibitors. Also, half of our patients had prior venetoclax. And because this was, what we consider sort of a heavily pretreated population, we really had an extraordinarily high risk population. Something like 70% had abnormalities in TP53 or complex karyotype. Virtually all of them had IGHV unmutated disease. So this was a group of patients that I would say is uniquely challenging to study. And we asked the question, can you beat the standard of care? So what is the standard of care? Well, that's challenging because there isn't one. And so we had to settle upon a standard that would pass muster with the FDA, pass muster with the doctors, pass muster with the patients. And what the control arm in this study was what we call investigator's choice, meaning the patient, in collaboration with the doctor, could decide whether or not they would receive idelalisib in combination with rituximab or bendamustine in combination with rituximab. Now, neither of those are great options in this population, but because there's an absence of a standard, the investigators felt like it was an appropriate control arm in this setting. And so patients were randomized 1-to-1 to receive either pirtobrutinib or the investigator's choice therapy. And for those patients who did receive investigator's choice therapy, if they experienced progression on their treatment, they could then cross over to receive the pirtobrutinib. So there was an incentive for those patients who didn't get the experimental arm. They could still potentially get it if their disease worsened.
So that's great. It sounds like you were taking patients who had prior therapy. Most of them had prior BTK inhibitors.
All of them had prior
All
BTK.
of
Yeah,
them
that was
had
that was
prior.
that was a mandatory criteria. Yeah.
All of them had prior BTK inhibitors. About half of them had prior venetoclax. And you were saying, is pirtobrutinib or this investigator's choice better in terms of the length of time they could stay off of treatment before any sort of progression? So what do you think were the important results you found?
Well, the way the study was designed was we were evaluating whether or not progression-free survival improved. Progression-free survival is a composite endpoint. It means you are both alive and your cancer has not progressed. And so I think to investigators in the field, the study results aren't really surprising. Pirtobrutinib beat the investigator's choice. And the difference was, I would say, somewhat modest when you look at progression-free survival, in that the PFS was around 14 months versus 7 months. So it doubled that, although I think all of us are hoping for longer disease control. This is where we get into some deeper analyses. One of the key outcomes we reported is time to next treatment. And the reason this is important is when you run a study, oftentimes you have to get regular CAT scans and so forth. And we know that patients with CLL, often who've been heavily pretreated, they can have lymph nodes that are very close to 1.5 centimeters. And if they get larger than 1.5 centimeters, it can be an asymptomatic progression. And in many cases, the doctor in consultation with the patient may feel like the patient is benefiting from the drug. And so the time to next treatment tells us sort of when they felt like the drug was no longer benefiting the patient. And that was actually quite a bit longer. sort of around 24 months. And we broke that apart by whether or not they'd received venetoclax or not. And so if they'd received venetoclax previously, it was about 20 months time to next treatment. And if they hadn't received venetoclax, it was roughly 30 months time to next treatment. So, roughly 2.5 or 3.5 years of disease control with pirtobrutinib in that setting. Kind of the other key findings were really about safety. Pirtobrutinib is a very well-tolerated drug. I've used it now in quite a few patients, and I have to say it's a medication that patients really don't notice that they're taking all that much. And so when we compared it to chemotherapy, such as bendamustine-rituximab, or the other the other standard arm, which is idelalisib rituximab, we really saw significant improvements in sort of all the safety variables, sparing pneumonia and neutropenia, which was relatively similar. All other criteria seem to be better. So you have a drug that gives improved progression-free survival, clinically meaningful event-free survival, and improved safety for the patients who receive pirtobrutinib, which puts it as an option for patients. And I suppose the last comment on that is the goal of this study is to get pirtobrutinib approved. Now it is approved already, but for patients, they may not always understand that oftentimes insurance companies and Medicare really follow these labels very closely. And so the way pirtobrutinib is currently approved is for patients who've received both a BTK inhibitor and a BCL2 inhibitor. But this study ideally will change that label so that it's for those individuals who have received a prior BTK inhibitor and eliminate that requirement for a prior BCL2 inhibitor, because those drugs are challenging for some patients. So that's the purpose of doing this.
Yeah, those are all really great points. And so currently, at least in the United States, pirtobrutinib is only approved after a patient has had a BTK inhibitor and venetoclax. But in this study, you specifically showed that patients who had not yet had venetoclax actually did quite well with pirtobrutinib. And so the hope is that patients would get access to pirtobrutinib early. And so in terms of getting a prescription for this, right now it really is only approved for patients who have had both BTK inhibitor and a BCL2 inhibitor like venetoclax. And at the current time, this trial is actually closed to accrual, so no further enrollment. But are there any other ways patients can access pirtobrutinib if they need it? Are there other similar trials that are ongoing?
Yeah, there's a number of other important studies going on. There's a study that combines pirtobrutinib with venetoclax, and I think that's important because some of the criticism of this study is that some investigators or some doctors may feel like after a BTK inhibitor or BCL2 inhibitor is appropriate. Well, we did that study too. It just hasn't read out yet, but that study will read out, and that gives us an ability to really say, in the relapse refractory setting, patients who've had prior BTK inhibitors, does the addition of pirtobrutinib help? And so for those individuals who are suitable for venetoclax, pirtobrutinib can be potentially a very useful tool to make that drug easier to use. But that's the question of the other study. So there's also studies potentially looking at this in the frontline setting that have compared it to ibrutinib, I believe, and possibly acalabrutinib. I don't recall the specifics of that study. That study probably has a long way to go before we get answers from it. So it's premature for me to speculate. And I think the field will have to digest sequencing of agents when that study reads out. That's an important question, which is, how can we use these in order? And that answer is not yet known. So, for now, it can be prescribed, and as you point out, it's for patients who've had both prior therapies. Different insurance companies may take a different degree of rigor with which they look at a patient's prior therapy. So, if pirtobrutinib is appropriate for a patient, they can potentially work with their doctor and see if they might be able to get authorization, but that's sort of beyond the scope of this discussion.
Yeah, no, that's great. So I guess to sum up this Bruin 321 study, this was for patients with relapsed CLL. Patients either received pirtobrutinib or the investigator's choice, and pirtobrutinib was shown to be superior in terms of time to next treatment and how long a person went before their disease progressed. Also had way better side effect profile. And so overall, I think this is a really important study. So I just want to thank you for all the work that you and the other investigators are doing to help folks with this disease.
It's great to see you, and thanks so much for having me today.
Yep. Thank you very much.